Hello, my name is Jack Hensien. I'm a first year internal medicine resident at Boston Medical Center, and I'll be presenting our group's work titled Finding Ferritin Footprints in 5-fluorouracil-Induced Cardiotoxicity. So to start with some backgrounds, 5-fluorouracil or 5-FU is within the class of chemotherapy drugs called fluoropyrimidines, which are widely used in the treatment of solid malignancies. And this includes gastrointestinal malignancies such as gastroesophageal and colorectal cancers. And along with other chemotherapeutic agents, 5-FU also comes with risks and side effects, including cardiotoxicity. And the fluoropyrimidines are actually the second most common drug associated with cardiotoxicity, secondary only to anthracyclines. And the risks of cardiotoxicity include, but aren't limited to, coronary artery disease, coronary vasospasm, as well as heart failure. And overall, the mechanism of 5-FU-induced cardiotoxicity isn't fully understood, although there's some evidence to suggest a relationship between iron and 5-FU-induced cardiotoxicity. In vivo studies have suggested that 5-FU triggers a process of iron-dependent cell death by enhancing transferrin receptor expression. And rat models have demonstrated that higher iron concentrations were found in myocardial tissue in rats treated with 5-FU compared to controls. Ferritin is an iron storage protein and also a readily available clinical laboratory assay. And given this relationship between iron and 5-FU induced cardiotoxicity, we sought to determine if ferritin could be a clinical biomarker of cardiotoxicity in patients that are receiving 5-FU based chemotherapy. So to do this, we performed a retrospective analysis with patients aged 18 and older who were receiving 5-FU based chemotherapy at Boston Medical Center from June of 2022 to June of 2024. Data were collected by manual chart review, and laboratory data was limited to those that were obtained closest to and within 24 months following the first receipt of 5-FU-based chemotherapy. We defined potential cardiotoxicity as the presence of new obstructive coronary artery disease, new wall motion abnormalities on echocardiography, a decrease in ejection fraction on echocardiography by greater than or equal to 10%, coronary vasospasm, pericardial effusion, or incident heart failure with a documented heart failure exacerbation in the medical record. We also evaluated treatment failure, which was designated as a clinical or radiographic progression of disease that necessitated transitioning to an alternate chemotherapy regimen, as documented by at least one attending oncologist. We performed statistical analyses in R and utilized a single imputation technique to address missing covariates in our dataset. If you'll direct your attention to Table 1, we retrospectively evaluated 93 patients in our study. The small majority of patients were male, with 30, 42, and 4% of patients identifying as white, black, and Asian respectively. 12% of patients in the study were determined to have potential cardiotoxicity, and 45% of patients experienced treatment failure during the course of the study. Figure 1a shows the odds ratios for cardiotoxicity in patients with ferritin values greater than or equal to 100 and iron saturation greater than or equal to 20. And those with ferritin greater than or equal to 100 were nearly 5 times as likely to exhibit potential cardiotoxicity. And similarly, in Figure 1b, displays the odds ratios for treatment failure in patients with ferritin values greater than or equal to 100 and iron saturation greater than or equal to 20. And again, those with ferritin levels greater than or equal to 100 nanograms per milliliter were approximately 3 times as likely to experience treatment failure. So overall, our findings suggest that elevated ferritin may foreshadow cardiotoxicity and treatment failure among patients receiving 5-FU-based chemotherapy. And this study was limited by its retrospective nature, as well as small sample size, where not every patient had complete data, and this included iron studies and ferritin. We attempted to address this by utilizing the worst case single imputation technique, where if a ferritin value was missing, it was presumed to be low or less than 100 nanograms per milliliter. So this hypothesis does require validation in larger cohorts, but a ferritin level greater than or equal to 100 nanograms per milliliter may be useful in identifying a subgroup of patients who deserve and would benefit from closer surveillance for cardiotoxicity. I'd like to thank Grace Ferri as well as Dr. Siddiqui and the other co-authors listed on this poster, and also the CTSI for the opportunity to present this project. Thank you.